Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh. This is, I don't want to say I have to pee when I'm on a road trip until it's, actually, I have a little hunch that Edna was a little tipsy when she filled Emmonsburg for him. What's up, guys? Welcome to the podcast. This is an episode on pain management. My name is Katie Kleber.
Hey, my name's Elizabeth Mills.
And I'm Melissa Stafford.
And we're going to do this episode on pain management because it is not quite as straightforward, I think, as I thought it would be when I became a nurse. Like, I thought it's like, oh, patient wants pain meds. Here you go. That's it. It's a little bit more involved in that. And it's a little bit more complex than that, too, because we also have a large issue in the United States with opioid addiction, which is what we use a lot for pain control in the hospital. So that's something that's very important to consider as well when you're providing care, especially if you have a patient that struggles with addiction. So we're going to talk about a few different important aspects of managing pain. And the first one is setting realistic expectations. So if I said to you, I'm going to treat your pain, that may mean something different to other people. For some person, that might mean, hey, it's going to be controlled to a certain degree. But to someone else, that might mean I'm going to have no pain at all. And it's important to be on the same page as your patient about what pain management, not pain elimination, will look like. Because some people, and I've definitely had patients before, expect to be pumped full of pain meds till they don't feel any pain.
Mm-hmm.
And that is dangerous. And I don't know if people realize how dangerous high levels of pain medication are. And have any of you had a patient that had too much pain medicine and you had to give them Narcan?
Oh,
Yeah.
yes.
Yeah. And I bet you asked 20 nurses, 18 of them are going to say yes. And Narcan isn't a medication you administer it's the opioid reversal agent. So it knocks off all the opioid receptor things, and all of a sudden they had no pain, and now they have all of it. And so avoiding that's really important. But the big first thing is to set realistic expectations. You had blank surgery, or you have a chest tube. You had a thoracotomy. That's a pretty painful procedure. Setting realistic expectations for what pain management is going to look like, and definitely differentiating that between pain and pain elimination. Did you guys have anything to add on that, or is that?
No, I think that's an important concept. Pain control does not mean pain elimination.
Yeah.
And I feel like that's a newer thing that we are getting into now, like differentiating that. I feel like it's newer versus.
I think, but I remember, reading and watching things about this whole opioid epidemic and how doctors express frustration where 10 years ago they weren't treating pain enough. And pain is this sixth vital sign. And give all these pain meds. And now we've tipped the scale.
Yeah.
And giving the exorbitant amount of pain medications that can be requested or people believe is appropriate. Non-physicians, the patient experiencing the pain may not realize how inappropriate that dose would be, and those kinds of things to consider. Next important thing is proactive education. So, like we said, a patient has blank procedure surgery, having a realistic expectation of what kind of pain they'll experience. So if they had a cardiac catheterization up their femoral artery, and they have chronic back pain, knowing that they're going to have to lay flat for a certain amount of time and expecting that's going to be uncomfortable. Once I had a patient that had that procedure and they had back pain baseline and they wanted a continuous morphine drip. And it's like, I can't begin to tell you how completely inappropriate that would be. Medically speaking, and how doing that would be negligent, but that's what you want, So setting those, providing this proactive education about what to expect. So, hey, I'm going to do a cardiac cath on you, but I see that you have chronic back going to be uncomfortable until we can get you up or whatever. You know, we're going to have to deal with being uncomfortable to a certain degree, you know, that kind of thing. Also very important to utilize pain scales appropriately. There's many different pain scales. The pediatric world has some. The most common one is the 0 to 10. Rate your pain on a scale of 0 to 10, 0 being no pain, 10 being the worst pain in the world. Well, worst pain in the world is very subjective. It's very, well, this feels awful and I'm experiencing it right now, so it's very easy to rate that as a 10. But realistically, a 10 means it can't get worse. It means you're unconscious. It means you can't communicate to me how bad this pain is so bad you cannot communicate. So if you can verbally tell me a 10, it's not a 10.
I love the stick figures with like
the blood
the
coming out
arms.
of their eyes.
Yeah.
This is a 10.
Like,
Yeah.
their limbs are chopped off and like.
I tried to put that in my latest book, or no, in that Admit One book for patients, but that wouldn't let me.
That was pretty fun.
Not very
I
sensitive.
had a
to-
nurse one time that said a 10 is like sticking your hand into a pit of fire. And I thought, well, that's pretty descriptive.
Or I've heard people say burning alive
Oh, well, yeah.
or being mauled by a bear. And I have said those to patients.
Neither
before.
one I want to experience to see what pain of 10 is really like.
Right.
But
right.
that, you know, that's an important point is, you know, I wouldn't even want to experience that kind of level of pain. So is the pain I'm really having a 10.
Right.
But, you know.
So it's important. So because if they're not rating it appropriate, because a lot of time your PRN medications will say, hey, Norco for moderate pain rated 4 to 6.
Yeah.
And Percocet for 6 to 10 and then morphine for 8 to 10.
Yeah.
So if the patient's not rating it appropriately, they're getting inappropriate medication administration. So it's important that they understand the scale appropriately. And it's also helpful if you're able to catch them before their surgery or before whatever, so that they understand that scale. It's easier to understand that when you're not in pain than when you are. Also, proactively, it's important to tell people, let me know when your pain is getting worse, as opposed, I am someone that doesn't like to bother anyone until it's unbearable, or until I don't want to say I have to pee when I'm on a road trip until it's unbearable. You know, like I don't want to alert the troops until it's absolutely necessary. But it's important to empower your patients and let them know you're not bothering me. I want, you know, if this Norco works now, it's important that I give that now instead of in 45 minutes when it's unbearable. And now that Norco doesn't work, or it doesn't work as effectively as it would have.
Yeah.
So that is really important to let, because I did have a patient, actually, I think only a few patients that expected after a surgery to, after not a, I wouldn't say minor, but not major, expected routine pain medication administration, oral pain medication administration, when I'm like, and I was a newer nurse, it's like, well, this is as needed. I don't bring this in until the patient wants it. And I ask him if he says he has pain. He says it's no, but he thought he was getting pain medication later.
Mm-hmm.
So the miscommunication, and he was upset. I got yelled at, but it was like, I didn't know he didn't know. So it's important to, you know, hey, especially if you don't have scheduled stuff and they don't have a PCA, it's like, but they had something kind of painful happen. Hey, let me know when you want your pain meds and let me know before it's an emergency. And I especially let people know that if the pain medication they have ordered, like maybe a back surgery patient has Robaxin PRN and we don't routinely keep that on the unit, I need to give myself more buffer room to get it from pharmacy.
Yeah.
So keeping those kinds of little practical things in mind. And one other thing I also like to ask proactively before pain is horrific is what's worked and what hasn't. Like I had a patient that had a thoracotomy once, and the only pain medication options I had was Percocet and 2 milligrams of IV Dilaudid.
Wow. That's quite a disparity there.
It is. But to me, the Percocet I thought was going to be appropriate. Well, Percocet makes her vomit. So that's not going to work for her. And I'm glad I asked her that before I had a thoracotomy patient vomiting, because that would hurt even more.
Mm-hmm.
But the 2 milligrams of IV Dilaudid was not appropriate. So I had, that was too much.
Gosh, I would have to be intubated if I had 2 milligrams of Dilaudid.
I would first throw up all over everyone, and then I would be unconscious for 3 days.
Seriously.
So it was like asking someone, hey, have you had this before? That I think that's important. It's a simple, easy question to ask, and you can avoid some frustration.
Yeah, and I want to add, being the neuro nerd that I am, a neuro consideration and that proactive education too, because pain medications will interfere in your neuro exam. They make patients drowsy. They can make patients act really crazy. they could knock them completely out. So one of my regular conversations that I have with my patients, as well as their families, is it's important for me to be able to balance pain control with your neuro exam. I want to be able to give you enough pain medicine to keep it bearable for you, but I have to be very careful about giving you too much medication where I can't wake you up and do the things that I need to do,
Mm-hmm.
because that might lead to some other things. And as long as I have found over the years that as long as I have that conversation on the front end with the patients and the families, because, the families don't like to see their loved ones in pain either,
Right.
Yeah, right.
that they have a better appreciation for the fact that, yes, so and so has a headache, but I don't want to give them any more morphine because it's getting really hard for me to wake that patient
Yeah.
up.
Mm-hmm. Mm-hmm.
That's kind of one thing that I like to do on the front end. The other thing is that pain education as far as what kinds of pain medicines they have ordered, whether they be IV pain medications or pills by mouth, is, a patient who's receiving nothing but IV pain medicines is going to be in the hospital a whole lot longer than the patient who can transition to pain pills. So, I had a patient who didn't like the way the pain medicine made her feel nauseous and didn't want the pills. So that's all she asked for was for IV stuff. And I said, well, I don't mind giving you the IV stuff, but if these pills aren't working for you, then I need to know that, and I'm going to go talk to the physician about getting some different medicines ordered. This doesn't have to be the only pain pill that you're getting. And that's exactly what happened. I went and spoke with a physician. He ordered 2 different kinds of pain medicines pills for her, and the next 2 days that I took care of her, she never had anything else IV, because then she understood that if I'm giving something by mouth, and I didn't really, if I'm giving you something by mouth, I can tell in the hospital if that's going to work for you at home. So, like your patient, if they have a prescription for Percocet and doesn't do anything but make the patient vomit, if she goes home with a prescription for Percocet, it's not going to do her any good. She'll wind
Mhm.
up back in the hospital.
Right.
But if I have had a conversation with the physician and they change her to Norco or Vicodin or Toradol or whatever, and that works for the patient, then now we have a plan for discharge. And now I know that I'm already going to be on a pain medicine that I know they can give a prescription for at home, and that patient's going to have good pain control at home as well.
And it's important, if you have a patient that's regularly receiving IV pain medication, to always be thinking about when are we getting oral?
Yes.
Why am I still giving, unless someone is intubated in the ICU, like this is the kind of pain management we need to do right now. But if you've got someone on the floor that's continually needing IV pain medication, we got to ask ourselves why.
Yeah. Is it a problem with the surgery?
Right.
Is it, something else going on that they need more attention for, more imaging studies or lab
Right.
work or whatever?
Right. Or does the patient think this is the only method of pain control, and they ask for it only because they didn't know they had another option, or they've said, hey, I need more pain meds, and the nurse just continually brings in what the last nurse brought in. And since maybe post-op 2 milligrams of morphine was completely appropriate, but all night they've been getting 2 milligrams of morphine every 4 hours or 2 hours, and the next day just continues it, when the patient should have been started on oral pain medications, but nobody kind of took that step.
Yeah.
So that's really, really important. So that kind of flows into the next one of providing predictability. So talking about that plan. Hey, you're going to experience some pain with this. We're going to give you some IV stuff for breakthrough pain, but ideally we're going to control this pain orally, because you can't go home on the IV stuff. It's going to take longer to get. The longer we're on that, the longer it'll take to get home. And you are going to experience a degree of discomfort when you're getting up and ambulating. But walking around is how you're going to get home. Those kinds of conversations need to happen on the front end to get people out of the back home faster. And ultimately, they do have better pain control if they have these realistic expectations. They've had a conversation with the nurse. They know the plan, because I think we assume our patients know more than they do, and patients don't always feel comfortable saying what they don't know, or maybe they don't even know what they don't know. So it's important there's no such thing as over communication in healthcare and any aspect of this. So it's important to do that. So like one of the things I like to do is have that conversation on the front end, and then tell patients, hey, this is the plan. You were getting 2 milligrams of IV morphine every 2 hours, but when I come in and do my first assessment, I'm going to give you an oral pain medicine. And we're going to see how that goes. I'm going to check back in after an hour. let's see how if that was enough, and then we're gonna ride that for another hour. I'll give you the next dose when it's due, and we're gonna try and stay controlled with this oral stuff, and then use the IV for breakthrough because we can always use that, but it's so important to get to that
Yeah,
oral
and
stuff.
it's important that the patient understands you're not trying to say you're not going to give them pain medicine.
Right.
What you're trying to say is, I want to make sure that I have you comfortable with medicine so that you can get up, you can move around, you can do your coughing and deep breathing exercises and be uncomfortable, but you need to not be over medicated and staying in the hospital too long.
Right. And you know what's funny is not funny, but I met a nurse from, I can't remember, Scotland or England or something, who was actually working at the hospital I was at. And I was very curious. She came from a system of socialized medicine. And how is that different? And I asked her, what do you think? Because she had been working in the US for quite a while at this point and had spent, at least 10 years working as a nurse in the other country. And her main difference, the main thing she said was, you guys give so much narcotics and opioids here. It's astounding.
Really?
She was like,
Well,
you
that's our
never,
culture.
yeah, in wherever she was from, it was somewhere in the United Kingdom, was that you never get IV pain medication in unless it's like cancer pain. But you guys give it away like it's candy here.
And I'm sitting here thinking, you don't give IV pain meds?
Right.
Really?
Right. So I was pretty blown away by that because out of all the things, the big differences between the two, that was the first thing that came to our mind. And we weren't even talking about pain meds or anything like that earlier. That was just the first. So I thought that was pretty interesting. But so that kind of leads into the next thing. So what do you do? Have either of you, question, because I know my answer, have you ever had a patient that you thought was manipulating you for pain medication?
Yes.
Yes.
Emphatic yes, me too. I've had patients ask me say they're allergic to everything except Dilaudid, which is not possible. Or they ask me to push Dilaudid very quickly. I've had patients tell me they want Dilaudid with Phenergan with Benadryl, all of which sedate.
Yes.
Yeah, I had a long time ago when we used to use Demerol more,
Mm-hmm.
and I had a patient who was like, "I'm not like bring me my Demerol and Phenergan every 4 hours," and I'm not kidding. Like, of course I'd say I'm nauseous, but then literally 5 minutes later, their loved ones would be bringing them up a cheeseburger and fries and a Coke.
And it's hard being the nurse because you feel like you're truly being manipulated to give drugs that are much more potent than heroin.
Well, well, I mean, we have a heroin epidemic in this country for a reason.
Mm-hmm. But so I was not prepared for this at all. I didn't know this was a thing until I was in this situation, and it was like, I just thought everyone was honest about their pain, and most people are.
Yes.
Absolutely. If I have 50 patients, I would say 48 of them are honest.
Well, and we've been taught a lot too that we cannot look at somebody and see what their pain level is.
Right.
So just because they can be awake and eating a cheeseburger doesn't necessarily mean they're not having pain. So, we as a nurse are trying to figure out a way that we can look at the patient, use our assessment skills, listen to what the patient's saying, and deliver safe dosing for pain medicines. And it's hard to do.
Mm-hmm. But, the reality is there are patients that suffer from substance abuse disorder that have painful things happen to them.
Absolutely.
And they need pain control.
Yes.
Or there's patients that don't have substance abuse disorder, but they have things going on where they require a lot more pain medication than someone else would. Various disease processes and whatnot. So actually, when I wrote a post about this a while ago, just asking other people how they handled it. But I came across a post that I really loved. It was written by Beth Hawks. She writes nursecode.com. I love her blog. She actually is a nurse educator and is a wonderful resource. And she wrote this great blog post called "How to Cope with Patients Who Have Substance Abuse Disorder." Got a link to it on my blog. If you just Google that, it'll come up. But she talks about 6 steps to really deal with this situation where you're frustrated that you see that the patient has a timer on their phone for every 3 hours, or you see you feel like they're lying to you, and you're spending more time dealing with that than with another patient who might not be stable, or like something like that. So how do you deal with it? And she said, first she breaks apart or defines the differences between tolerance, dependence, and addiction, right? So those are very different things. And I wanted to go through those differences real quick so that you kind of also had the same definition. So tolerance is a normal physiological response to exposure of a substance over time. And I'm actually reading straight from her blog post. She says, think coffee. You require more caffeine to realize the effects you enjoyed when you first started using, which she crosses out, drinking coffee. There's tolerance to side effects, which includes sedation or nausea, like from opiates. So you're more tolerant of those side effects. Tolerance to analgesic effects, which require higher doses to achieve the same pain relief, or the same doses of coffee to achieve the same levels of alertness. So normal doses of, maybe normal in our eyes, doses of pain medication after a specific surgery aren't normal to that person with a level of tolerance. So that's tolerance. Dependence is physical dependence, which develops with repeated exposure to opioids. And the American Society of Pain Management for Nurses position statement says tolerance, withdrawal, and physiological dependence are expected responses to opioids and are not by themselves indicative of addiction. And then she goes on to discuss the definition of addiction as defined by the American Society of Addiction Medicine. Addiction is a chronic primary disease of the brain characterized by an inability to abstain. People with active addictions can't control their cravings or impulses. And here's the thing though, patients with active addiction, it's hard for me to say, active addiction, have pain as well. And perhaps they may even have more pain than other people that are undergoing the same procedure. She says there's I'm not going to be able to say this right. There's a phenomenon known as opioid-induced hyperalgesia. I'm not saying that right. I'm sorry. In which patients who depend on opioids have increased pain despite increasing doses of meds. Which I thought was very interesting. So that's kind of I thought it was really important to have a definition of that, because I just thought you just want the pain meds, but it's much deeper than that. Mm-hmm. And then but then it's like, all right, how do you practically deal with that? So she goes over 6 steps, which I will have a link to so you can look at what she wrote. But the first thing she says is to check your judgmental attitude at the door. And she says, I remind myself that I don't know how this person got to this place. What are these factors that led to this addiction? Any things like, did his father leave him? Did someone hurt him? Was this person utilizing drugs to kind of deal with that? Was that their coping mechanism? Reminding ourselves that we haven't walked in their experiences. So I think that was really important and a little humbling to see step 1 of check my judgmental attitude, but I completely agreed with it. The next thing that she says is to be realistic. Let's be realistic that if someone, her example was people with DKA have high blood sugars. So people with substance abuse disorder, they're going to display specific, behaviors. So let's not be surprised by that, I guess. You know what I mean? The next thing she says is to understand your job. You're definitely not going to cure this addiction in this, most likely when someone's admitted, especially not for their addiction, they're not there to get it resolved. They're probably there to deal with whatever primary medical issue is there.
That's so maybe something I feel like I take home with me more than anything when I'm dealing with this situation was I'm not there to cure them.
Yeah.
Or,
to cure the addiction. Yeah.
And how likely even if you wanted to, how likely could you, when you're dealing with someone who has an addiction, that maybe they were in a car accident, or maybe they had to have their appendix removed, or maybe they had to have whatever happened that brought them into the hospital. Maybe it was because of their addiction, but regardless, like, we still have to deal with the pain or that issue, and the addiction is just another layer of it.
Right.
And we're in the acute phase of treating blank, and treating addiction is a very long process.
Yeah.
So understanding your role in whatever step. Of course, maybe you are an addiction nurse, and this is very different than approaching this situation is very different. The next thing she said is to take control of yourself and not your patient. If you're angry, it's your anger. If you're frustrated, it's your frustration, not the patient's. And I love how she says this: I can only be manipulated if I allow it. So I thought that was pretty profound.
Mm-hmm.
The next thing she says is to not engage in a power struggle. And when this happens, you and the patient lose. And I'm going to just read directly from what she said. I've worked with nurses who use passive-aggressive behaviors and forget to medicate their patients. Wait until after change of shift or whatever. Failure to treat pain is profoundly wrong, unethical, and unprofessional. Nurses who position themselves as she or he as the gatekeeper of pain medication really need to rethink of how they're using their authority.
Mm.
Which I
I
thought
think
was,
it's very important.
It's pretty strong. It's
oh
a
yeah.
really good point.
Mm-hmm. I love her blog. Y'all got to read her.
Clearly.
I've never read a post from her that I did not think, dang, that was really good.
Mhm.
So yeah, she's a wonderful writer and wonderful nurse. And the last thing that she says is to be professional. Again, I'm going to read what she wrote. I won't use stigmatizing terms such as drug seeker or clock watcher. In handoff report, I will simply inform the next nurse when this patient's pain med is due. This patient deserves the same access to medication as Edna, my 78-year-old female post-op hip surgery patient, and the same dignity and vigilance. Actually, I have a little hunch that Edna was a little tipsy when she fell down and broke her hip.
Good for Edna. I'm just kidding.
Yeah, really.
I will respect this patient as a fellow human being for who all I know is doing the best that he can with what he has, as we all are. So with that,
That's
I
really good.
think that kind of wraps up our pain medication episode. Unless you guys had anything else to add on the topic.
So takeaways: educate your patient.
Mm-hmm. Set realistic expectations.
Yes.
Provide predictability. And when you find yourself dealing with a patient that you believe you actually know or you believe has an issue with substance abuse disorder, check your judgmental attitude. Be realistic. Understand your job. Take control of yourself and not your patient. Do not engage in a power struggle, and be professional. And also, it's really important to touch base with the provider and make sure that you have a plan in place for pain management that the patient is in on, agrees upon. And if you have a patient that suffers from substance abuse disorder and there are certain pain medications ordered and the physician is going to make changes to those, that physician needs to speak with that patient.
I agree.
There's no discontinuing this 2 milligrams of Dilaudid every hour.
And just disappearing.
And
Yeah,
disappearing and
really.
not that conversation for the nurse is challenging enough. We need to treat this as a team mentality, and the provider needs to communicate, this is the best, I believe this is the best step. Are we all on board?
Absolutely.
So, and that's part of proactive education. You can't make those changes without everybody being on the same page. All right. Well, thank you guys so much for listening. If you want to check out nursecode.com, she has a wonderful blog. A lot of her posts are directed towards new nurses. So I highly encourage you to check that out. Check out freshrn.com/blog or freshrn.com/podcast for some show notes. And make sure to check out her specific blog post on nursecode.com entitled How to Cope with Patients Who Have Substance Abuse Disorder by Beth Hawks. Thanks, guys. Stay fresh.
Damn girl, better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got the heat.